Hello, everyone. Thank you, Chair. Thank you, Professor Davidovich, Ms. Yael Ben-Chaim, and the organizers of this important meeting. My name is Dorit, Professor Dorit Nitzan. I'm the director of the Emergency Medicine Department in the School of Public Health in Ben-Gurion University of the Negev, working with Professor Davidovich, and nice to see you all. I'm here to discuss the ethical considerations in emergency preparedness and response. And many of the issues that I'll highlight to you today are actually those that we learned from the pandemic. The pandemic has shown us that really we are living in one world, one connected world, where all of us are one. We are sharing many of the emergencies. We have a diversified portfolio of hazards and emergencies. The climate change is there, wars and conflict, food and nutrition insecurity, social determinants of health, and many other threats. But the biggie is that emergencies expose the diseases of societies. During emergencies, it is easier to see what are the failures and what issues, values, and norms are tested or coming to the rescue. We have been challenged with global versus national, local capacities and views. How do we see ourselves? How do we see humanity? Decision-making has been challenged with pull and push and stretching vectors. Many times the decision makers were questions, were not given the chance to explain, and many times people actually did not get it. Command control coordination systems in some countries had to be repurposed or restructured as ad hoc approaches, since in peaceful or routine times, they were not done in the right way or not planned well. And of course, we'll discuss it a bit, the universal health coverage versus market forces has been challenged big time. The basic principles of bioethics through the emergency cycle management are in a way mentioned in the Universal Declaration on Bioethics and Human Rights of UNESCO already in 2005. Some of the issues I marked here, but some are missing, and some we do know today need to be considered when we go with better planning for better future. Because when emergencies occur, people are usually expecting to have it all and always. They want to have full access to diagnostics, to medicines, to vaccines and technologies, and of course, to be safe, respected. And we all want to exercise our rights at all times. But that requires long-term investments and decision-making to make those investments in prevention, preparedness, response, and recovery. But more than that, in the basic good universal health coverage. So some ethical dilemmas, I would like to highlight for us some of those ethical dilemmas so that we will all be on the same page when we in the future meet and try to discuss. So the first dilemma seems to me actually to be or not to be, and to me it's equal with prepare or not to prepare. And this is actually rooted in societal norms and values that view preparedness as a public health good. But viewing preparedness as a public health good has to be a notion, because some people would say, well, why should we be prepared? Emergencies occur once in a while, we take the risk and we just live through it. But for those of us like me who believe that this is actually a question of to be or not to be, that calls for some work at the side and great investment in resources, in expertise and partnerships, in engaging communities, investments in health and public health systems and workforce, and complying with global decisions, resolutions, and agreement. It needs to be done during peaceful routine times for the resilience that we all need against health emergencies at all times. So that also requires the implementation of the great tool, a great global mass salvation tool, the International Health Regulation 205, at global and local levels. And of course, it has to be based on the humanitarian values of humanity, neutrality, impartiality, independence, and the notions of human responsibility, so solidarity, mutuality, and accountability. All of this must be anchored in universal health coverage, and that means that all people and communities should have access to a wide portfolio of care that would avoid catastrophic payments, but also provide safe, good quality, seamless, continuous, people and community-centered health services through life and anchored in the community as a whole. Investing in the health through universal health coverage at all times would actually make the emergency response much easier, because this health, the well-being, the livelihood, the security, education, trust, happiness, all of these issues will start from higher level at the emergency and not at the bottom of health status, etc. So when we speak about this dilemma and we want to be prepared, resilience against health emergencies comes into notion. And here we need the good governance with whole of government approach, whole of society, one health, all hazards, and leaving no one behind, rooted into the norms, values, culture, and perceptions of societies, yielding the prevention, preparedness, and universal health coverage fruits that are so important for our life and livelihood. The second dilemma is, first, do no harm. Many of the decisions that we make during emergencies are decisions that require some knowledge, some understanding, but many of them are done and taken under uncertainty. So here we should agree before emergencies how to get the evidence-based clinical trials. For that, WHO can come to the rescue, as there are many protocols, and also to decide when to advise the community and when to commend it. What to do with new technologies, medications, and vaccines, how to deal with them. What do we do with one for all and all for one? Is it real? Do we want to vaccinate children to protect adults, or to vaccinate people to protect other people? What about adverse events? How do we monitor? What do we do with the results? And who is accountable after all? Who should decide? How to decide? All these questions and more are bringing us directly into the third dilemma, which is leaving no one behind. Here we are actually targeting the distributive justice issue, which is, for example, who to vaccinate, treat, and provide special care, how to allocate and to whom to allocate the scarce resources, to whom, how to ration. What about the health workforce? How do we protect them? And the public health capacities, are they there? Do we have them in order to ensure that people can do and can provide the job, deliver the job that they are asked to do? And the fourth dilemma is about autonomy, dignity, and human rights. Here we saw many of the clashes between personal responsibility and social responsibility, the punitive approach versus rewarding approach, or just approach, limiting movements, or just advising, tracking and tracing and intelligence, activating martial laws in some countries, finger pointing and stigmatizations of groups within our societies. And of course, here we have to touch another issue which the COVID pandemic has revealed, and that's the cutting edge with a cutting edge. Do we decide that from certain age, people are not eligible for ECMO to be hospitalized in ICU because there are no machines? Who to decide? Who should decide? And how to decide? And de facto, if we did not decide, can we look at the data and see who actually in retrospect was treated with those technologies or the advanced technologies, the cutting edge? This has to be agreed, probably in routine, peaceful times prior to the emergency itself. And something that I saw in my role in WHO, the COVID outbreak, pandemic, is some countries or some communities are not ready to send or to welcome humanitarian assistance. In the sending part of humanitarian assistance, we saw that some countries are using the realpolitik, bilateral agreements, and helping this and that, but not that and this country, while the global prioritization actually guides us in different manners. Also, some countries did not use the correct platforms for sending or receiving emergency medical teams or the global outbreak and response network. Are we ready to receive? Are we ready to send? Well, sending in Israel, we're very proud. The IDF, the Israel Defense Force, the emergency medical team has been in many places already. Nitzan, Israel, and many more have been in many countries already. The seventh dilemma is access and benefit sharing during emergencies. Very important. This is the key for developing medicines, diagnostics, and vaccines. Because sharing biological samples, there are global agreements and there are standards how to do it. The IHR also guides us. And there are many platforms to share also goods. So looking at the beyond me but also including me, and understanding that we are as strong as the weakest link helps us to actually share and care. The eighth dilemma is the health and beyond workforce. The decision who are the frontliners in health, social, educational workforce, inclusive, do we care for them? How do we protect them and make sure that they receive what they need? How we care for them? What are their obligations? What are the expectations from both sides? And what is the compensation package? We cannot accept and wait for people to fall apart, to really get sick and not be able to deliver and care for themselves and their families. We need to make sure that surge capacities in each of the workforce is there, planned and taken care at all times. And that brings us to the ninth dilemma, which is community engagement. Here we learn that we need to listen versus hear. We need to involve and engage. We need to actually engage and involve, and we need to get people that can feel that they are part of the machinery. We have to do communication, but very much risk communication that is tailored to the need. And we also have to understand where is the time to say no is no and yes is no. Yes, time to rule and role to rule. This is bringing us to the 10th dilemma, which is no regrets policies. This is very important. It's very important that the decision makers will do as much as they can, procure even more. But who is the one, or who are those that have the no regrets policy activated for? And For how long? And is there a good risk management body that actually does the monitoring, evaluation, accountability, and bioethics reviews at all times, making sure that this is not exploited? And because in the no regrets policy, we see that people can and should be safe to make these decisions as long as there are those bodies that are monitoring and transparently auditing what needs to be done. And the 11th dilemma is thinking beyond the me, here and now. Humanity is part of our planet. So we have to look at the One Health considerations and understanding that when we care for one, we might harm the other arms, the plants, the animals, and the environment. We have to think of the generations to come. We have to rethink the fact that maybe representative for the generations to come should be part of those bioethical lens that should be integrated into the decision-making. That we saw with the schooling issues, universities, schools, students, pupils, how to deal with it, who is either to decide, and how to balance lives and livelihood. These issues are very important. And again, research and development during emergencies, key to have. Without them, there won't be any tests, any cures, and any vaccines. And WHO has a tool, and that tool is called the Emergency Use Assessment Listing, the emergency list, that when it comes for the rescue, it comes with a package of a kind of insurance, making sure that what we do is facilitated through the WHO to ensure compensation for individuals suffering from serious adverse events through some kind of insurance. This is countries that agree and work together globally. They are part of this. And that team is a people-centered team that agrees and decides how to get all the countries and the donors work together to ensure that the people that use the vaccines or medicines and got severe side events would be cared for. So that is bringing us to the important one, and that's adding the ethical lens into the emergency medical cycle. In the command control coordination structure of each of country, it is important to include, at least that's what I believe, also technical experts on science and research to be supported by the Emergency Ethics Committee, that all SOPs, all actions, all decisions and activities, all initiatives will be reviewed also from that lens. And the bioethics optics will be integrated into the decision-making side of things. Because we understand that many of the decisions are counterbalancing. Many are trying to balance the situation with the context in the specific country and community. But from the wisdom from hindsight, to me, it seems very clear that no man, woman is an island, and no country is a lonely planet. We are all connected. We do have global health diplomacy. We do have global platforms to help us to work together. We have, the list is long. I mentioned here only 6, but the list is long. We do have those tools, and we are also strengthening now as the world, including here from Israel, the International Treaty on Pandemic Prevention and Preparedness. It is not touching by any means any sovereignty of any country. This is just to help humanity to work as one, because as I said before, and many said before me, no one is safe until everyone is safe. So shukran, I thank you very much for all your time. I'm sorry that I won't be here with you to actually help and answer any questions. This is Professor Dorit Nitzan from Ben Gurion University School of Public Health. Thank you very much.